Hey everyone, welcome to our first webinar of the year, Optimized Treatment Zones in Ortho-K, presented by Precision Technology Services. I'm Dr. Steve Turpin, General Manager of PTS Optics, and for the first webinar, I got the opportunity to sit down with renowned research and clinical scientist, Randy Kojima. We cover a lot of ground in the lecture, but our main point is to address why shrinking the optical zone size of an Ortho-K lens might increase the myopia management effects and actually slow the axial elongation of patients better than a traditional Ortho-K lens. I don't want to spoil the rest of the webinar for you guys, so just sit back, relax, and enjoy our conversation about optimizing treatment zone sizes in Ortho-K.
So really, Ortho-K started out as very much an adult-oriented lens. And really, in its maybe modern construction from the millennium, has been to essentially provide freedom from glasses and contacts, an alternative to refractive surgery. Patients that work in dry environments where maybe the air conditioning is causing issues with their soft lenses, patients that really wearing contact lenses in their activities is kind of challenging. So again, the Ortho-K lens was designed for adults. It was not designed for kids. It wasn't until 2005, relatively recently, that we found Ortho-K actually slows down eye growth. And this seminal study from Pauline Cho and her team at Hong Kong Polytechnic was the first to publish on using orthokeratology lenses in children, and they found that it basically slowed down the eye by about 50%. So when we look at the studies today across the planet, we see that average is around 48%. Now, Steve, could you take us through what does 48% mean? Is that like literally every patient we fit in Ortho-K has half the eye growth that we'd expect if we didn't fit them with Ortho-K? Or, can you provide some perspective here?
Yeah, Randy, sure. So, basically what we're talking about is we're looking at the average progression of the study group versus the control group, right? And so, when you look at an average, you then have to look at either the standard error or the standard deviation really to know exactly what's happening. And I think it's pretty safe to say that in these studies, you get variable treatment effects. Is it every single patient grows half as much as their controlled matches? No, absolutely not. We have some individuals who don't progress any differently than those who are in the control group. And then we have those who actually don't progress at all. And to really understand what the variation in that growth is in the control group, you really got to look at those deviations, either the standard deviation or the standard error, to understand that. But I think it's pretty safe to say across the board variable responses. And so here on this slide, you can see a little bit of variation in those averages. Part of that has to do with the average age of the patients who were studied in the Kojima study in 2011. That was a little bit of an older age group, a little bit of an older cohort. And so they're just in general, by the way that we understand how children progress in myopia, older children, 12, I think was the average age, tend to progress a little bit less than those who are, around 8 or 9, which a lot of the other studies looked at. So when you're looking at a study, always good to look at who's being studied, what their age is, what their baseline axial length and their baseline refractive error is, so that you can kind of compare apples to apples when you're comparing treatment efficacy across different treatment types. And we'll touch on that a little bit later, but I'll kind of let you get us there before we dive into that.
It's interesting, isn't it, Steve, that we can't look at two separate patients and say, hey, I know that we can achieve X with you, and the same thing with the next patient. We would, no matter what the intervention, whether it's Ortho-K, soft multifocal lenses, atropine, we have no idea, do we, which patients will really respond exceptionally well and which ones won't at all, and then there's everything in between, right?
Yeah, sure. I mean, we have ideas. We're starting to get a better understanding of what might make someone a good candidate and what might kind of increase their chances the best. Obviously, if we're using an optical treatment, Ortho-K, for example, a 1 millimeter pupil patient, not that there's a ton of those walking around, probably going to, not have as much of a treatment effect as someone walking around with a 6 millimeter pupil, right? So there's a few kind of those characteristics that we can look at to predict, but you're right. You can't point someone out and say, you're going to get this much treatment effect from this from this therapy. If we did, then we'd have this thing figured out and we wouldn't be having a webinar, right?
And I think the take home from that is it's really important not to overpromise and underdeliver with your parents, especially, that they need to understand that this treatment typically creates this amount of effect, but can we guarantee it? Absolutely not. Now, we followed about, I think it was 300 and something eyes over the consecutive Canadian patients fit in orthokeratology. And the idea was to understand trends. Who are we fitting? And one of those characteristics that we were looking at was the age of patient fit in Ortho-K. And as you can see, there's a real influx at the age of 10 years of age. That's where we seem to really kind of start out fitting orthokeratology in children. Of course, there are kids that present as myopes much earlier, down to 7 years of age during this study period, and kids that started out much later as well. But it certainly seems to be around that 10 years of age. That's when in Canada we're starting to really fit orthokeratology as a myopia control device. Now, what was interesting to me was how many patients were adults fit all the way up to 50 years of age. 16%, of adults were fit in orthokeratology. And that was shocking to me, that we have such a high percentage of adults being fit with orthokeratology. I thought this had really become an absolutely myopia control tool, and we just weren't fitting any adults anymore. Steve, going back to your residency, you fit a ton of adults at Pacific, and I know you've fit plenty since. Does this represent an average that you would recognize, or were you really more focused on the myopia control side? And if you are fitting adults, or were fitting adults, why were you fitting them? Why were they interested in Ortho-K?
Yeah, I mean, obviously, I shouldn't say obviously, because it might not be obvious for some practitioners, but in most practices, the large bulk of your Ortho-K fits are going to be in children that your goal is to get the myopia management effect out of the lens. Now, there's a couple reasons why you might fit an adult. In my practice, one of the things that the stories that I told, a patient would come to me and would say, hey, I don't want to wear glasses. I struggle. I tend to be quite symptomatic when I wear soft lenses for my correction. What are my options? You take a look at them. They have some early signs of dry eye. It might not be a moderate or severe patient, but they've got some not so healthy looking meibomian glands. Their tear film looks a little bit unstable. That's the patient that I'm going to talk to them about Ortho-K, as opposed to, they might bring up the topic of refractive surgery. And so, as we're seeing more and more of these patients who are starting to have dry eye pathology earlier and earlier, that's really where I found the bulk of my Ortho-K fits coming from. Patients who wanted to be free from glasses and contacts during the day, but that I was concerned that a refractive surgery may actually exacerbate their dry eye symptoms and lead them to be much more uncomfortable, maybe not this year, maybe not next year, but 10, 15 years down the road as that kind of dry eye disease progresses. And so by offering Ortho-K to those patients, then they kind of achieve what their goals are, and we can keep those corneal nerves intact, keep that feedback pathway driving tear production intact, and we don't have to disrupt that. So for me personally, that's really the target or the population I was targeting when we were talking about adults in Ortho-K.
Well, thanks, Steve. I was surprised when we polled the practitioners on each of these adult patients. It was surprising how many were medical staff, nurses, more specifically. There was quite a high percentage of medical practitioners that had been part of this adult cohort. Well, let's get back to our question. Can we do better than our orthokeratology that we are fitting today? Does the 6mm optic zone, that's always been the workhorse construction for Ortho-K, is that where we should be with myopia control and not adult fitting? So to understand the construction of an Ortho-K lens, you get the sense here that the tear layer profile of an Ortho-K lens creates its deepest reservoir at around 3 millimeters from center, or a 6mm diameter. So where you see that reservoir, its deepest point again is 6 millimeters across. That's where you have the highest suction force. We found over the years, or I shouldn't say we, the pioneers in orthokeratology determined that 6 millimeters was ideal for adult Ortho-K. That seemed to create a big enough treatment area, that blue treatment zone you see on the right-hand side there, to provide quality AM to PM vision for most adults. Certainly, adults with big pupils were going to have more problems with flare and glare and may have to wash out. But for the most part, 6 millimeters was kind of the sweet spot for adults. Now, here's a standard 6mm optic zone lens. This is kind of what you would say dominates the industry in most brands of lenses. Now, what do we expect when we place this lens on a patient for myopia control, as an example? So let's take a conventional adult-oriented lens, put it on a child. And here we have an outcome where the Ortho-K effect has created 3 diopters, 3.01 diopters effect. Now, I want you to concentrate your attention on this graph down below. This is the cross-section of power that exists through the pupillary area especially, and then beyond. And what you notice is on the apex, the corneal apex, and what would be presented to the fovea, you have a 3.01 diopter effect. However, toward the pupil border, you have a drop or loss in of effect of 1 diopter. If you think of this like multifocal soft lenses, what ad do you place on a child for myopia control? Would you put a 1 diopter ad in the soft lens for myopia control? Not a chance. You'd be using a minimum of 2, probably 2.5, maybe 3, maybe 3.5. You're pushing a lot of plus power, a lot of defocus. So for this patient, we've really done a very poor job of myopia control because we're only pushing 1 diopter of ad. Well, let's take this lens off the patient, the 6mm optic zone lens. Let's put it on another patient. We're creating about the same effect, around 3 diopters, in this case 3.03. We have a nice, beautiful centered blue treatment zone. Optically, it's really doing what we want it to for myopic reduction. But then you look at the most minus to least minus, so your 3 diopters in the center going all the way down to -1 effect at the pupil border, you essentially have a 2 diopter add. So better than we had for the previous case, but maybe not as high as we could create. So this is an improvement, but really we've just taken the lens off of patient A and put it on patient B, and we have 2 totally different outcomes relative to the myopia control aspect. The myopic shift is the same. Now let's take that lens off that patient, put it on a third, and again, we're creating 3 diopters effect, 3.05 diopters. But when you look at the most minus to least minus, now we have a 3 add. So we're kind of getting into the range of what we would do with soft multifocal lenses in myopia control. We're pushing the plus, we're pushing that add power, that defocus into the eye. So with these 3 different cases and the same lens, we get totally different outcomes. And you'll notice with our first case, the upper case, we have big treatment zone, small amount of add, a modest amount of spherical aberration. With our slightly smaller treatment zone, more plus power, increased spherical aberration, we have a whole different effect that's presented into this eye. Then for our final, smallest treatment zone, highest amount of plus power, highest amount of spherical aberration. Steve, is this an egghead thing to do? I mean, this is definitely research oriented, that we're looking at the power shift, we're looking at the spherical aberration. Is this something that practitioners are doing today? And should they be looking at this?
That's a great question, Randy. I would say certainly more folks are looking into this. I mean, anybody who fits Ortho K, who's had a few fits, knows that in certain cases it's hard enough to get that patient where they're happy, good treatment zone centration, everything like that, right? And so once you've kind of reached that level, at least traditionally, it's kind of, wipe your hands, you've done a good job, pat yourself on the back, you have a successful Ortho K wear. Now, as we begin to understand more about what is actually driving the myopia control effect, which, as you've pointed out here, we think, and the evidence seems to suggest that also, that increasing spherical aberration and that reducing that treatment zone size provides a more substantial myopia management effect. And so as we understand that relationship a little bit more, I think it will become more standard of practice to assess the treatment zone size, to assess the degree of increase in spherical aberration, so that we have a better understanding, we can better communicate what we think, the potential for myopia controlling effects to be of the treatment.
Oh man, so true. I mean, the instruments are not yet providing for you an easy assessment of these metrics. That's one of the first problems. And the second problem is we don't know what patients need a high add and a low add to achieve good myopia control. So it's kind of a bit of a gray area at this point. But as you said, it's our understanding is evolving, which is great. That the amount of research in myopia control is just incredible. Every month there's something new. And as Steve said, the story with myopia control is when we fit orthokeratology or soft multifocal lenses, the higher the power shift, the higher the amount of plus that you push into the eye, the better the myopia control. The higher the spherical aberration, the better the myopia control. So it seems pretty clear today what we want to do with our orthokeratology lenses especially, and most likely tied absolutely the same way to soft multifocal lenses, is to increase the blur. We want the foveal correction to be appropriate, of course, but it's what we do toward the periphery that seems to be a key in creating better myopia control, slowing down the eye growth. Now, here's a bullseye topography. This is what we might say is the optimal outcome in orthokeratology. I hope you're all pretty happy with the centration of this blue treatment zone on the axial map. Let's switch over to the tangential. We see a red ring that really follows the border of the white pupil. Things are looking pretty good here. This is our optimal bullseye. But what Steve and I want to ask you is, okay, you've created a good bullseye. You're happy. As Steve indicated before, often we look at our outcomes and say, is the slit lamp signs acceptable? Is the patient's vision appropriate? Is subjectively, does the patient have any issues with comfort or handling of the lens? If all those things are good and we have a good bullseye, let's let them go and see them back in 6 months to a year. Well, maybe we should be looking at our treatment up front. And to do that, what you're going to do is go to the Axial Subtractive Map. And this is to look at the myopia defocus dosage, or what you might think of as the add power you're creating, or the amount of blur that you're pushing into the eye. So go to the axial map and then look at your cross section of power that presents within the pupil. So that would be across this white line right here. What is the most minus and least minus that you have within the pupil? So you're going to go to the center, what's right on the visual axis, and determine the RX change. In this case, 4.25 diopters. Then we're going to go to the pupil border and we click our cursor right on this spot here or on this spot down here, and we determine the power is plus 75. The absolute difference between those two would be 5 diopters. So we're thinking that we did an awesome job of orthokeratology for myopia control because you have so much blur, so much add being presented into the eye on the peripheral retina. So this is one of the ways that you can get a sense right up front. Are we doing a good job of not only Ortho-K, but Ortho-K for myopia control? If you're coming up with a plus 75 add, we probably want to make modifications to the lenses before we have this patient sent away for 6 months to a year to find out, we let this eye grow because we hadn't pushed enough blur into the eye. Now, another way that you could approach this is with the Numeric Meridian Map. Steve, can you give us a sense of how we use this? It's a lot of numbers, and to me, Numeric Meridian Maps always get kind of confusing. How do you assess this axial numeric meridian map?
Yeah, Randy, I think, like you said, a kind of gut check, so to speak, on this stuff is it's great to look at the cross section, and that kind of gives you a pretty clear idea. If you want to understand, kind of the whole treatment zone size and what's going on within that treatment zone across the whole pupil, you can look at the Numeric Meridian Map to actually see how much that refractive surface of the cornea has changed post-treatment relative to the baseline. And so you can see here in the example, right there at kind of the center, and Randy, you can point there, we're getting about 4.4 diopters of effect. And then as you move away in the different directions, you'll see that amount of effect become lower or become less and less. Because now you're getting into less change in that surface, less flattening. And so moving forward, one thing that I think will be really interesting is, instead of us just looking at the cross section, if we can continue to develop some resources to basically evaluate that whole pupil area as a whole, much in the same way that we evaluate things like higher order aberrations. by using the root mean square to evaluate that and put a number on what the whole area is doing, not just that cross section. But for now, either using that cross section or looking at the numeric meridian map to kind of get a more focal understanding of what's going on where, and that pupil is a good way to understand what you're doing there in the center in the pupil area.
You know, it's a good point. If you're in the audience and saying, okay, I get it, I need to have a big shift in power from the center to the periphery, what axis should we put this line at to appreciate the graph? And as Steve says, we don't really know yet. Is it the flat meridian? Is it the steep meridian? Is it the average of powers all the way around that gives us the number? Is it the axes of the highest amount of plus being pushed into the eye? You know, we just don't know at this point. We do know that the bigger the power shift, the slower the eye grows. So that's where we're at in the research, but let's stay tuned. I know our group is working with Hong Kong Polytechnic on a study to understand this exact question. Is it the flat, is it the steep, or is it the average of power all the way around? Now, another thing that we can look at is spherical aberration. And you see pre and post Ortho-K. Before Ortho-K, the spherical aberration in millimeters was 0.439. Post was 2.523. So we have had a shift of something like 2.1, a massive shift in the spherical aberration. The research hasn't given us the exact number, how high we want to push the spherical aberration. We don't know that at this point, as Steve said. However, if you look at the Lau paper, it suggests that patients that were in that 0.3 millimeter power shift, that positive increase in spherical aberration, did not have good myopia control. Once you got up to 0.8 positive shift in spherical aberration, those patients had good myopia control. So it appears that we want to not only push as much as we can, but definitely looking in the range of an increase around 0.8. Now that probably is going to depend on the refraction the patient had, you know, how curved the retina is. There's a lot we don't understand, but what we do understand is if we're not making the spherical aberration go up, then we're probably not going to slow down eye growth. Now, another thing that we wanted to look at was how different is the Ortho-K effect for various RX changes. So looking at a conventional 6 millimeter optic zone, what kind of myopia control signal are we providing, knowing that Ortho-K cuts the eye growth by about a half? So what we did was we looked at the myopia defocus dosage, the amount of add or plus signal being pushed into the eye, and then again, the spherical aberration. And here are the findings. What you're looking at here on your y-axis is the effect that we've created, the myopia defocus dosage, the add power, the blur that we're creating. And then along the x-axis, the various RX changes. So notice for the 1.5 diopter effect, so if we're just creating a low orthokeratology treatment, a low myope, you don't have a ton of dosage signal of myopia defocus dosage. However, for the higher myopes, you got a much higher signal, much more plus, much more blur. So there was a difference between fitting a patient with a low myopia and a high myopia. If we switch over to spherical aberration, you see a similar story, that the low myopes had a modest amount of signal. The higher treatment effects, the 4 diopter effects, had a much higher spherical aberration increase. So Steve, this might lead us to question, do we get better myopia control fitting a higher myope versus fitting a lower myope? Should we be doing something else for that -1 patient?
Yeah, Randy, I mean, that's a good point. You know, my answer in that circumstance is, you know, you'd have to really be able to have, you know, a full cohort of patients that had, you know, everything else, you know, the same, age, age, onset of myopia, things like that, but just different powers to be able to, really answer that question. Do we get more effect from a higher treatment versus a lower treatment? Someone who's has a diopter and a half myopia versus 4.5. So I would say, don't throw your Ortho K lenses out the door if you've only got a -1.5 or a -2 in your chair. A lot of the studies that we're looking at are working on patients who are kind of have that average of a -2, and we're getting the effect that we're getting with the the traditional 6.0 optical zones. So I definitely don't think you can go wrong by fitting the lower myopes with Ortho K if you're hoping to control any more progression.
To my knowledge, there isn't a single study that has really teased this out, as Steve said, unless we're actually looking at these cohorts really definitively, then I don't think we have a story. However, what we do have is the HM Pro study out of Pauline Cho's group at Hong Kong Poly that was fit on high myopes. And so it was specifically the high myope group. And I think her findings were that if you fit patients with at least 4 diopters of a myopic shift, if you were creating 4 diopters effect, that the axial growth was in the neighborhood of 58% less. So her study showed you got slightly better axial control using Ortho K on high myopes specifically. But there could be other reasons for that, such as the eye's already grown to create that 4 diopters effect. So I guess, as Steve said, we don't have to be concerned. At least we don't think we have to be concerned that the low myope won't get the treatment that you want them to. Now, why is there a difference? And this is an important understanding relative to the story of building better orthokeratology lenses. Here's a treatment to create a 1 diopter effect. And I want you to concentrate your attention on the graph down below. Notice how little tear layer profile difference you need between the center and the reservoir depth to create that tiny little 1 diopter effect. It's a very subtle difference in the thickness of the fluid in the center versus the thickness of the fluid at the reservoir, deepest point of the reservoir. Now, that creates a modest effect on the eye. So most minus, we're getting 1 diopter on the fovea. At the pupil border, we're getting a 1/4 diopter effect. We're creating a modest add here. Now, is that enough for this patient to slow down eye growth? That's a question that can only be proven out over time from here to the next visit, but I'm pretty concerned that that's not a lot of add. Let's look at what we do with a 4 diopter patient. Here you can see having that very flat base curve to cornea relationship, at least 4 diopters flatter than the radius of the eye. You've got a much bigger differential between the thickness of the fluid at the apex and the thickness of the fluid at the peak of the reservoir. And that, of course, gives you a much bigger difference in corneal epithelial change, where you look at the center, we've got our 4 diopter effect. At the pupil border, we have -75 effect. We've got a 3 1/4 add. So when we place our orthokeratology lenses on eyes, we also have to be aware that we really have 2 very different suction forces at work, and this should probably be manipulated to improve the myopia controlling outcome, to get more defocus into the eye. So when we build an Ortho K lens today, we want to be concerned that we are creating enough myopia defocus dosage, regardless of if we're fitting a low myope or a high myope. We want to, as the researchers suggest, err on the side of more plus pushed into the eye, more spherical aberration, max it out the best you can to the point that you don't lose visual acuity. One of the experts in the field, Earl Smith, at the University of Houston College of Optometry, is regarded as one of the experts in this field of myopia control and myopia development. And when you ask Earl what we should do, he says, push the maximum plus, push the maximum blur that the young patient can handle. So if, for instance, you were using soft multifocal lenses and you push a 350 add and the patient has blur, has aberrations, then you back it off to a +3. If the aberrations are still too high that they can't be managed, then you back it off a little bit more. Now, when you look at these three effects here, you have a -1 treatment with its modest change, a -3. Now the tear reservoir depths in the neighborhood of 50 diopters, a -5, the reservoir depths in the neighborhood of 77 diopters. So you can imagine how different these three lenses would perform on eye to create that myopia defocus dosage or spherical aberration change. So we have to be cognizant of these three things, that we are needing to influence treatment zone size, we're needing to influence the add power we're creating, and the spherical aberration. And as you can probably guess, all three of those are tied to each other. You have bigger treatment zone, you have less add. You have bigger treatment zone, you have less spherical aberration. As you shrink down that treatment zone, you increase the defocus, you increase the spherical aberration. So how do we enact change in orthokeratology design? And one of the principal ways is to modify the size of the optic zone, where the reservoir has its greatest suction force. So there's generally three optic zones that we use most frequently today. The smaller two, 5.0 and 5.5, are used for myopia control. The larger 6 millimeter for adult patients. You might go a little bit smaller in optic zone on an adult with a high RX, and that's a way you can achieve the 6, 7, and 8 diopters effect. But for the most part, it's a real dividing line. 6 millimeter optic zone and above is generally reserved for adults. 5.5 and smaller, generally reserved for kids. So what does that mean exactly? A conventional 6 millimeter optic zone would have its peak of the reservoir at 3 millimeters from center, or 6 millimeters across, peak to peak. That's where the deepest point of the reservoir is. If you use a smaller optic zone, in this case a 5 millimeter optic zone, then 2.5 millimeters from center, you're going to have your deepest peak of tear film underneath the lens. So we're going to manipulate the position of where that suction force on the epithelium is. And that's a way that we can influence treatment zone size, myopia defocus dosage, and spherical aberration. And you can see that here, where with the larger 6 millimeter optic zone, you get this very flat, as Steve calls it, a shallow U-shaped treatment area, where we're not seeing a radical shift from the center to the periphery in power. We maintain a more uniform myopic reduction. Whereas with the smaller optic zone, you notice you go away from the U shape more toward a V shape, where you have this very quick change from center to periphery. We're losing that minus effect. We're pushing more plus into the eye. We're getting less myopic shift toward the periphery. So when you fit a orthokeratology lens without asphericity, using a conventional spherical optic zone lens, you have, in this case, a 6 millimeter optic zone, spherical base curve that gives us 70 microns of reservoir depth. Let's put on a 5.5 millimeter optic zone, again without asphericity in the base curve. So what happens is, when you reduce the optic zone size without increasing asphericity, your reservoir depth is getting lower. If we go to a 5 millimeter optic zone, we've dropped in elevation of the reservoir down to 52 microns. So Steve, if we were to simply change the optic zone without adding that asphericity element, and we see that we get less tear film thickness, what do you think is going to be the result when we compare these three optic zones?
Yeah, well, I think, Randy, you can look at some of the studies that have come out that have basically asked this question. What if we just change the optical zone size? And what we typically see is that the treatment zone size, what happens on the cornea, isn't as dramatic as we would expect, right? You get only, if you fit a 6 millimeter OZ or a 5 millimeter OZ and you don't adjust the asphericity, you don't get that much difference in the actual treatment zone size or the amount of change on the cornea. Once you add in that asphericity and you actually get equivalent tear film thickness and tear reservoir depth, that's where you start to see those dramatic changes in treatment zone size. And when I say dramatic changes, I mean kind of that shrinking of treatment zone size by maintaining the fluid, what's the word I'm looking for?
The forces?
Yeah, the forces, exactly. Hydraulic forces. Thank you. It's like you said earlier, past my bedtime, so my brain's trying to remember the words at this point.
Yeah. So this, everybody, is such an important part. If the treatment zone size is kind of a key element of modern orthokeratology construction, the asphericity, we might argue, is equal in terms of its importance in this whole story. So here's the same kind of scenario where you have a 4.5 diopter therapy target and a 6 millimeter optic zone with 70 microns of fluid thickness. But now when you go down to a 5 millimeter optic zone and you include asphericity in the base curve, you're essentially making the optic zone flatter and flatter toward the periphery. It's not one uniform radius. You get much deeper fluid layer, equal to the 6 millimeter optic zone. Same thing with a 5 millimeter OZ. Using a even higher amount of asphericity allows you to maintain that tear reservoir depth, as Steve says. And the research makes it pretty clear that if you change optic zone alone without changing asphericity, you're not going to have the same myopia controlling effect. So these two things really go hand in hand. And this has been proven out with the VOLTS study out of Hong Kong Polytechnic. And again, Pauline Cho's name keeps coming up because she's kind of the diva, the queen of myopia control research, orthokeratology, soft multifocals, you name it, atropine. And what she wanted to do was study the difference between a super small optic zone, the 5 millimeter rather than the 5.5, and the 6 millimeter. And the idea was to see, do you get a really big difference when you compare those two optic zone sizes? And it's the typical patient that you would enroll into orthokeratology, the typical Hong Kong patient that's Asian, young, myopic, and needing some kind of intervention. And this was using the B-free lens alongside the Medmont topographer. Now, what they wanted to do was look at the treatment zone size. That was one of the metrics that they wanted to evaluate. And what you're doing is you're looking at the point where the eye doesn't change. So when you do orthokeratology and compare pre versus post, at what point do you see really no difference between them? So you get this big central flattening. Beyond that, you get a steepening. But what happens? What's that point in between? That's regarded as the treatment zone size. And what they found was that when you use a smaller optic zone, a 5 millimeter optic zone versus a 6 millimeter optic zone, the treatment area is nearing a millimeter smaller. It's 0.72 millimeters smaller using the smaller optic zone. That makes sense. You'd expect with that reservoir being out here for the 6 millimeter, moving in for the 5 millimeter, we should have a big difference in effect, and we do. Now, what's really important is not just this big shift in treatment zone, it's how this alters the myopia control signal, the defocus and the spherical aberration. And what they found was that the 6 millimeter optic zone cut the eye in about the eye growth in about a half, but the 5 millimeter optic zone near to stopped the eye from growing. I mean, that would be an exaggerated statement, but what's exciting is that we had a much better myopia controlling effect using the small optic zone. And the way it worked out is the conventional B-free with a 6 millimeter OZ, an adult OZ, slowed down eye growth by about 48%, just exactly in the middle of the average of all our myopia controlling studies. But the 5 millimeter slowed down eye growth by 88%. So this is even better than Ortho-K plus atropine. You've probably seen combination treatments where we're using soft multifocals and atropine, or orthokeratology and atropine together to slow down the eye growth. And the small optic zone story is actually more powerful than combination treatment. Now, this is the 1-year data. I know that Ella, who's doing the study, she's the PhD candidate. She has completed her 2-year data, and she'll be publishing that very soon. So I'm excited that we'll have some 2-year reporting on these findings. So one of the interesting things about this study, as well as a second study that happened in Hong Kong using the B-free lens, again, a lens you could get from Precision Technology, is that with the Medmont together, these two created an average of 96% first fit success. It was awesome. Steve, what does that mean? What could you give us some perspective on 95% first fit success? What does that mean to you? Is that relative to other studies? As an example, is this what we get with all Ortho-K lenses, for instance?
Yeah, Randy. Every single manufacturer is going to, pick the best study that they have and say this is our first fit success rate. And so, anybody that you ask, it's going to be over 80%. Usually over 85%. And I always tell people, this is study data. This is perfect conditions. Should you expect to fit 95 out of 100 on the first fit in your clinic? Probably not. But some of the things that we can take away from this about how to increase your first fit success is, I really think it comes down to, that point that you made about the Medmont and the B-free and capturing good quality topographies. That's really kind of the quintessential step in using a topography system like the B-free system, where it's being designed off of the patient's topography. And, we manufactured the lenses for this study, and I will tell you that the maps that came in were great. They were beautiful, super high quality maps, which allowed us to build really accurate and precise lenses to lead to this 95% first fit success rate for these patients. And so if you want to start, getting into this first fit success rate, that's kind of playing with this, really get comfortable and get your staff comfortable with taking really good quality topographies and providing, good information and picking good candidates as well is another point to that.
Well, man, you're speaking my language. I'm such a crazy about getting good baseline data. I couldn't agree more. So why the high first fit success here? And for those of you who are relatively new to orthokeratology, or you're thinking about Ortho-K, I think that one of the keys behind this high success rate, and how maybe more importantly you can be efficient in practice, is the MedMont topographer is really one of the best instruments for specialty contact lens practice. It's certainly proved itself out in more than a handful of studies in contact lenses, dozens and dozens. So with the right tool, taking good quality maps with well-trained technicians, but also from the perspective of the lens design, using a platform like the Be Free, where it's automating the lens construction. There won't be transposition errors, for instance, in taking topography data, punching it into a software, having it design the lens. You're not going to have those errors because it's automatically done by the system. But one thing that I think is really different about this lens design is that you are designing toric lenses for patients who even have a hint of toricity in the eye. You are trying to optimize this 360-degree landing so you get the best centration and you center those hydraulic forces to get the best possible outcomes. So this is, to me, a key, is marrying these two systems together, a topography that's accurate with a automated system that that builds lenses in this kind of ideal manner. Steve?
Yeah, Randy, thanks. So I basically wanted to kind of build off of what we learned from the 1 year results from the Volt study. And one thing that I'll touch on, Randy, is, you talked about kind of the difference in treatment zone size that we get with the Be Free 5.0 versus the Be Free 6.0. And I want to touch on this subject again, because I just think it's so important, is that the Be Free does obviously have that asphericity in the base curve, which does allow us to maintain that tear layer depth, and actually results in that kind of neat, smaller treatment zone in the 5.0 than you might get with another 5.0 optic zone that doesn't have that asphericity. So moving on from that, basically I wanted to look at, now that we have this information from the study with the Be Free, how does it compare with some of the other optical myopia management strategies out there? What are we looking at in terms of efficacy versus with this treatment versus some others? Because most folks who are providing myopia management are providing more than one therapy, and so we want to be able to communicate to our patients, which patients will always say, well, I know you told me about these 4 options, which one's the best? Obviously that's going to depend on a lot of different factors, but as we get more information, we may be able to provide them more specific information. And so that's kind of what I wanted to do here. So when we look at the kind of parameters of the study, and we're looking at age groups, we're looking at how much myopia the subjects had, and what the starting axial length was across the study with the dim spectacles, the MySight study, another Ortho-K study that Pauline did earlier, that was a 6.0 Ortho-K study, and the Be Free, all pretty similar in terms of baseline characteristics. When you do the t-test, most of these come out that we can't separate these patients, that they're not statistically different. So it allows us to actually look at them and compare. The biggest thing that you see is there's more subjects in the SPEC study in the MySight than there were in the Be Free, and we'll kind of talk about how that shows up when we look at the results. So if you'll hit the next slide, Randy. So here, what we see is the absolute change in axial length, or the average axial length change in the treatment groups after 12 months. So as Randy said, the data has been published in the Volt study for 12 months, soon to be published in 24 months. So we're super excited to see that. But if we look at what has happened over the first 12 months across these different treatments, you'll see that the DIMS, MySight, and a standard 6.0 optical zone Ortho K lens all perform similarly, and that the B-free, as Randy said, kind of gives us this kind of eye-popping effect. Now, the one thing you will notice is that in both Ortho K studies that we're looking at, the difference in standard deviation of those results is much higher. And part of that, I would say the majority of that, is due to the smaller sample size. The less subjects you have, the smaller the sample size, the more standard error, standard deviation that you're going to have. So the standard deviation in the other two treatments is tighter due to more subjects. And so just something to keep in mind as you're comparing. I wanted to put in the control bar here on the right, and that is basically when you look at, all of the, not all of the myopia management studies, but a lot of the myopia management studies, that's kind of an average progression that we would see in this age group in the control population that's either wearing single vision spectacles or single vision contact lenses. We get this about 0.33 millimeters of axial length growth in that control population, which factors out to about 1 diopter in that first year after you started following those patients. So you see that all of the treatments slow down the growth relative, but the B-free seems to do it, at least suggested in this first 12-month study, to do it better than any of the others. And so what we see here is that we now basically took what the last slide was, what was the absolute average change, and now we're looking at, well, if we compare the control group to the treatment group, what do we have as far as a difference? And so all three of the bars in blue, the treatment group was whatever the myopia management treatment was, and the control was a single vision control, either spectacles or a single vision contact lens. Now, the thing that kind of makes the VOLT study a bit unique is that there was no true control group, no control group that was in a single vision product. We had the 5 millimeter optical zone group, and we had the 6 millimeter optical zone group. So what you get when you compare the 5.0 to the 6.0, you don't get as dramatic of effect because the control group was still wearing Ortho K and they were still getting a myopia management or myopia control effect. If you took the results from the B-free 5.0 millimeter group and compared that to a quote average control group, that's what gives you this bar on the right. If you compare the progression rates of the 5.0 to the progression rates of an average control group of the 0.33 millimeters in a single vision product, you get a fair bit better effect than you do in some of the other treatments.
Hey, so I think what we hope that we could pass along to you is what we need is to try to affect the treatment zone size, spherical aberration, and myopia defocus dosage. The way we can do that is with the treatment zone size, but also in combination with the asphericity of the base curve. And any modern lens needs to take into account these two things. So there are two designs available to you from Precision, the B-free and the Moon lens, and we'd want to encourage you to reach out to our team if you have questions about getting started and maybe questions about which lens fits into my practice better, because they are different in their fitting approach. They both share the same central optic zone and that tear layer profile. So you can expect that its myopia controlling efficacy should be very, very similar. Hey, Steve, I guess we're kind of at the end. We've gotten excited and used up our time without finishing all our slides. But any closing thoughts?
Yeah, we certainly know how to use up a chunk of time listening to ourselves talk, don't we, Randy? Basically, kind of how I want to leave this. I think we covered, obviously the most important points. I think, what we had left to talk about just kind of centered around, okay, we know the story, we know why, creating a smaller treatment zone might be better for our pediatric patients. What are the details about starting that? And as you said, you can use either the Moon Lens or the Be Free. We've got a ton of resources at PTS Optics. We've got information on the website. We've got videos on our website on YouTube. We've got written resources that we can provide you, and then we have super knowledgeable consultants that can talk to you about all of that fitting, how to get started. About Medmont topographer, since we touched on Medmont, all of those things. So really, if you've listened to what we talked about and what we had to say and are kind of on board with this smaller optical zone, smaller treatment zone size, you basically just need to get in touch with us and we can help you kind of get that implemented and get that started. Or if you're already doing some of this stuff, take it to the next level in your Ortho K practice.